Good morning, ladies and gentlemen. Welcome to our media briefing update. I know we haven't had one in a while, but even with that gap, you did have opportunities to speak to the Premier and the MECs. So today we will have our briefing, and we have the Premier and the MEC for Health and the MEC for Infrastructure Development, as well as the members of the advisory committee and Professor Shabir Mahdi from VETS. As we normally do, we will start with science. So the advisory panel and Prof. Mahdi will speak to you about what they see in the pandemic, and then we will talk about some of the work that we are doing on infrastructure, as well as the vaccination rollout program. And of course, the Premier will give his closing remarks, and we will take your questions. All right, I would then like to call Dr. Mary Kawonga to come and start the presentation.
Thank you very much. Good morning, Premier, and good morning, members of the media and the public. So, as Mr. Masebe mentioned, there'll be three presentations, just one after the other. I'll start, Prof. Malado will follow, and then Prof. Mahdi, and then I'll come back and do a wrap-up before the Premier and the MEC take over. So, as usual, we start our briefing by looking at the epidemic curve for Gauteng, and as you can see there in the graph, that's the epidemic curve. We're currently in the post-second wave phase of the pandemic, and over the last 6 weeks, the numbers have been fairly stable at around 300 or so cases a day. But in the last 1 week, we've been seeing worrying spikes in the number of new cases. And as you can see on this graph, the latest numbers from last night for yesterday was 688 new cases. And this is double the numbers we've been seeing in the past week, a few weeks. And so that's the status. I'm going to go into a little bit more detail about some of the numbers. I just want to go back a little bit, because we're usually we present the week-on-week change in the pandemic. And I just wanted to sort of get that out of the way before I go into details about the last 1 week. So the two complete weeks we have data for are the week ending 24th April and the week ending 1st of May, as you can see in that table. And when we compared those 2 weeks, last week we did a comparison of those 2 weeks, and we actually saw that the number of new cases was about 15 to 16 per 100,000. The number of new hospitalizations were between 2.6 and 3.4 per 100,000. The number of COVID deaths were 0.5 to 0.4 per 100,000. The percentage test positivity was 4% the week prior, and then it went up to 5% the following week. And so at that point, we actually felt that we were still in a fairly stable position, but we were seeing an increase in the number of cases week on week by 4%. And because the percentage positivity had gone up by 1 percentage point, it was something that we thought needed to be monitored very closely. And as we've seen for the numbers from the 30th of April, we have seen that has been, the number of increase in cases has continued, and we've seen some spikes and also an increase in the percentage test positivity. And it's now sitting between 5 and 6% in the province. So 5 and 6% is not very high, but it's the fact that it's gone up from where it used to be 2 weeks ago. It was 3.6%, the average. And if it's gone up to 6%, that is still something that is fairly significant. I want to go into a little bit more detail of the numbers we've been seeing since the 30th of April. So first, I want to present this graph. If you look at the graph there, what we did is, one of the things we like to look at in the data is patterns. So we've been monitoring patterns on the number of reported cases per day, Monday, Tuesday, Wednesday, Thursday, up to Sunday. And the usual pattern we've been observing is that on Monday, Tuesday, the cases are fairly low. They escalate on Wednesday, Thursday, Friday, they're fairly high, and then they come down on Saturday and Sunday. And as you can see from those lines on that graph, those are the lines for the 6 weeks up to the 25th of April 2021. So there's a fairly consistent up plateau and then down again. But then what we've noticed in the last 1 week, since 30th of April, if you look at the black line, starting from Friday, which was the 30th of April, we had a spike in cases. The spike, the number of cases went down a little bit up to Sunday, but not sufficiently. They were still higher than the normal, what we've been seeing ordinarily for the past 6 weeks in terms of Saturday and Sunday. And if you look at the red line, that's now the number of cases that we've been seeing since Monday this week. So you can see the pattern is the same, that it starts off from a lower level on Monday, it goes up Tuesday, Wednesday, but it's at a higher level. So the number of cases are double the number of cases we saw Monday to Thursday last week. So for example, Thursday last week, we were sitting at just under 300 cases. Thursday this week, we're on 688. And if you do the comparison for Wednesday, Tuesday, it's the same. There's a big difference between those. So that's worrying us, because it's showing us that the numbers are higher than what we've been seeing, even though the patterns are similar. We asked ourselves whether this might be due to increase in testing. When we looked at the testing numbers that have been done Monday to Thursday this week, the number of tests has gone up, but slightly, not more than 10%. It doesn't account entirely for the increase in the number of cases that we're seeing in that red line. So I just want to go on now to the 7-day rolling average of daily cases, and that's the graph. You can see there the blue bars are the new cases per day, and the orange line is a 7-day rolling average. And in the last 7 days, we have seen a spike. Actually, it's an uptick, because it's actually a sustained increase in the 7-day rolling average for more than 5 days. So we're now on day 7, where we've seen a sustained increase in the 7-day rolling average of daily new cases. So we have not reached the third wave threshold yet, but we are very worried. We're concerned about the spike. And there are a number of areas that are concerning us in the province. And that's the box on the right. I just want to talk to those issues a little bit. So in terms of the increase we've been seeing in the last 7 days, all our districts have seen an increase. Some of them at a lower level than others. The highest increase have been in Johannesburg, Tshwane, and Sedibeng. And then the sub-districts that are reporting the highest number of cases are Johannesburg D, Tshwane 3, and Mfuleni in Sedibeng. Mfuleni is actually the most worrying area. It has had the highest number of new cases per day, per week in our province for 3 weeks. It's been a sustained increase in Mfuleni, and actually the numbers in that area are approaching the third wave threshold. So that's a concern. The other concern is we've noticed from the teams that do contact tracing and response to the pandemic, that the teams that do monitoring of compliance to non-pharmaceutical interventions have identified that people have relaxed their adherence to NPIs. And this has been seen in places of entertainment. We've seen that in some schools where they have sporting events, we've seen clusters of cases showing up in schools, clusters of cases showing up in workplaces. Also in families, clusters of cases have been identified. In Sedibeng, there was quite a big cluster identified, for example, in Vereeniging. So all of those are showing us that the numbers are going up. The behaviors are also not showing adherence to NPIs. So if you put those two factors together, it's actually a recipe for an even bigger increase in the number of cases and potentially even sparking a wave of the third wave. So now I'm going to hand over to Prof. Malado. And Prof. Malado is actually going to give more details about the mobility in the province, as well as the resurgence and third wave risk indices for our province and districts and sub-districts. And he's going to talk a little bit more to just highlight why we're concerned about the numbers that we're seeing currently. Thank you.
Thanks, Dr. Kawonga. Premier, MEC. So as Dr. Kawonga indicated, we're going to go through a number of indexes, especially risk indexes, based on which we express our concern about the seriousness of the situation. One of the important things we monitor on a weekly or bi-weekly basis is patterns of mobility, how much people are moving in the province and the different districts, because mobility drives a lot of the transmission within the province. So if we have a large number of cases, but also high mobility, we have all the elements for the resurgence of the pandemic. So what you see here, there's a bunch of curves. This comes from Google. Google provides data at the level of the province for different types of mobility. And what you see here is that we are now at the level of mobility we had right before the second wave. That's a big source of concern. You can see there that there was a dip that corresponds to when the lockdown was reinstated. Mobility went down, but now the mobility has restored to a level that is very close to the second wave. So that's a very big source of concern. We not only look at Google data, but if you look at other sources of data, for instance, Facebook doesn't provide different types or many different types of mobility, but it goes deeper into the geography of our province, where you go down to the district level. We have data from the city of Johannesburg, Tshwane, Ekurhuleni, and Citibank. And you see there, if you look at the lower graphs, the dark blue graphs, we are now at a level of mobility very close for each of the sub-districts and districts, before the second wave, confirming the trends that the Google data are showing us. So that's a major source of concern in light of the increase in numbers that Dr. Kawonga has alluded to. Now, we build a bunch of risk indexes that collate a lot of information. We have two types, one that uses classical analytics, another that uses artificial intelligence, with which I will close my presentation. You have an interactive map of the distribution of risk indexes for different provinces. So the first thing to notice is that the Gauteng province is surrounded by provinces that have a lot of activity, for which the risk is either medium or high. You can see there the Free State, which is the province in South Africa that has the highest risk of resurgence. You can see the graph there, where the curve has gone up and past the high risk. You have also the corresponding graph from the Northern Cape that shows a sharp and stark increase in the risk that has just surpassed medium and is heading towards high risk. That's a very big source of concern as well, because there is mobility between people, between provinces, that will enhance the probability of transmission in our province as well. Now, if we look at our province, let's look at the risk indexes and the situation of the risk in our province in terms of districts. As Dr. Kawonga correctly indicated, if you take our province as an average, the risk is not yet even medium. Overall, it's low. But the problem is that that risk is not distributed evenly in the province. One of the first things to note, you look at the graph there, is that Citibank, for quite a number of weeks and even months, has been very high. And now that we are seeing a resurgence in the number of cases, it is above medium and shooting up to high. And that's a very big source of concern, because that's exactly how waves start. Waves don't start with large numbers everywhere. Waves start with large numbers that are localized in certain communities or certain areas. Citibank is certainly one of them. That's not the only source of concern. If you look carefully at the line, the graph corresponding to Tshwane, you can see now that the risk starts to grow as well. So that is not a good sign. So if we look at the number of cases, the cumulative or the total number of cases distributed according to district, you can see there that Citibank still has a linear growth. It's not exponential, but is much faster than other districts. You can see that Citibank has overtaken the West Rand, and that is not a good sign. We can look deeper in those graphs. I'm not going to go through all of them. There's a lot of graphs there, but we look now deep in terms of sub-districts. We build risk indexes for different sub-districts. Well, you notice that in Johannesburg, there's certain sub-districts of Johannesburg where the risk is now growing, and that is a very source of concern. Some districts have, most of them or all of them have low probability of resurgence, but the probability is growing, meaning that we may be going towards the next wave. If you look at the second graph that corresponds to Tshwane, you can see that a number, especially 2 sub-districts, are experiencing growth of the risk of resurgence becoming greater. That's yet another sign, and the graph that you see below there corresponds to Ekurhuleni. One way to illustrate in an easy to see or easier to appreciate way is the number of cumulative cases so far in the pandemic. You can compare the number of cases in different districts and sub-districts of our province. And you can see there that Johannesburg D, where Soweto is located, where we seem to be seeing a resurgence in the number of cases, now has overtaken Tshwane 3. So they used to have a similar amount or less numbers. Now the numbers are higher in Johannesburg D compared to Tshwane 3, and that is a significant source of concern. The sub-district that is the most worrying of all right now, because it's displaying a quasi-exponential growth, is Mfuleni. You can see there in the purple line that is growing so much faster with respect to any other sub-district in the province, indicating that there is a significant number of cases developing there. We are now paying a lot of attention to the creation of hotspot clusters in order to ascertain where exactly the source of those cases are. And I will close my presentation before giving the floor back to Dr. Kawonga. We have also developed and released a few weeks back an algorithm based on artificial intelligence. The advantage of that is that we put all the pieces of information that are relevant to the pandemic together into a comprehensive indicator. And what you see there, what you have to focus on is the red line. You can see the red line going up and then down, but now up again. What you want is the red line to always be below the threshold, below the orange line. Now what happens here is that we had, since Friday, a resurgence in the number of cases. We had an uptick in the index. That was followed by not so big numbers on Sunday and Monday, but then we have now a resurgence in the number of cases, indicating a tendency for the risk to increase. And that basically is telling you that something is happening in the data that is inconsistent with a situation of stability, that stability may be broken and we may be going towards a third wave. That's why we are very concerned. So I'm going to give now the floor back to Dr. Kawonga to conclude. Thank you.
So good morning, Premier, MECs, and good morning to the media. So what I'm going to do is I'm really going to present to you the latest results of a survey that we did to see what numbers of people have actually been infected in the province and to see how it might actually differ across the province. So this is what is known as a sero survey. And for people that are not familiar with the sero survey, what it's all about is that we test for antibody in the blood. And that antibody tells us not that someone is infected or sick at that point in time, but it tells us that that person has been previously infected with the virus. So when I talk of a sero survey, we're trying to measure the percentage of people in different communities that have been infected by the virus until a particular period of time. So this particular sero survey was actually undertaken from the 4th of November 2020 till to the 22nd of January 2021. So obviously that's about 3 to 4 months ago. And as all of us know, Gauteng experienced its second wave, which started around about the middle of December. And consequently, what we were able to measure was largely infections that took place during the course of the first wave, with some of the infections that have taken place during the course of the second wave. But the sero survey actually stopped, or we completed the sampling in the sero survey before the second wave peaked. So all of the numbers that I'm going to present to you is really a very conservative estimate as to the number of people that have likely been infected in the province of Gauteng. The way we actually did a zero survey is that we randomly selected households in different sub-districts. So what we're able to do is not just give you a provincial estimate as to the number of people that have been infected, but we can actually provide you estimates down to each sub-district with regard to the number of people that have been infected, and that also helps us to understand what to expect in the future in the different sub-districts in Gauteng. Now, when we go about, we randomly select these households, and then we ask the individuals that are living in those households to provide us some blood. And all that we do is we take what we call a dry blood spot, which means you get the needle prick, and we put it on a full piece of paper, and then we measure the antibody in that blood spot. The zero survey, as I mentioned, was done across 27 sub-districts of the province within the 5 districts, and we eventually were able to sample just over 5,500 individuals. Now, the one important thing to just keep at the back of your mind when looking at these results is that when you measure antibody, one of the problems that we face with the virus is that that antibody, especially in people that have got mild infection or are asymptomatic, that antibody can actually wane, which means it disappears after a few weeks. So if we do a zero survey many weeks after the epidemic has peaked, what will happen is that there are people that might have been infected, but we won't be able to detect the antibody any longer in the blood. So again, these sort of zero surveys are informative, but it might underestimate the number of people that have actually been infected if it's done too long after the wave has actually passed. So as you can see, the bottom graph there basically shows that individuals with asymptomatic infection or mild disease, their antibodies will disappear after 4 weeks. So even if they were infected, we won't be able to pick up that antibody, and I'll show you how that materialized in the zero survey. So as I mentioned, the start date of the zero survey was around about the end of October, and we completed just around about the middle of January. And as you can see from this, the start day of the zero survey was about roughly about 2 months after the first wave had subsided. So again, important to emphasize that when we're doing it so late after the first wave has subsided, we will be underestimating the number of people that have been infected with the virus, because some of them will now become what we call seronegative. So what did we do? Eventually what we did is that as part of the zero survey, we also tried to find out from people how many of them were previously tested for the virus. Of the 5,000 people that gave us information, 771, 15% of the people were previously tested for the virus. And that comes out to about 150 per thousand of the population in Gauteng that were tested with the virus. Now, the reason why that number is important is that number is almost identical to what the rest of the country has reported in terms of the number of testing that's been done per thousand of the population until around about the middle of January. So it tells us that this is probably a very representative sample in terms of what has actually taken place in Gauteng. Now, of that 15% of people that were tested for the virus, 15% of them tested positive previously. Now, this is not on a zero survey. This is a test they previously had doing a PCR test, the nasal swabs, where we look for active infection. So 15% of the people that were tested for the virus reported that they were previously positive when they were tested. Now, of that 15%, and very important again, what we find is that only 47% of them were seropositive. Right? So what is the reason for this? As I mentioned earlier, you get this waning of the antibody. It disappears. Right? So 1 out of every 2 people that was probably infected before with the virus, the antibody is now negative if we're testing for antibody too late after the epidemic has peaked. So all of the estimates I'm going to give you is really an underestimate as to what likely happened. In fact, the numbers I'm going to give you, when I give you a percentage, you can multiply it by 2, and when I give you an absolute number, you can multiply it by 2. And that is probably the true number of people and the true percentage of the population that have actually been infected with the virus. So demonstrating this is that when you look at what the positivity rate, the percentage of people that were being tested, what the positivity rate was just before the second wave started, that remained fairly stable at just under 20%. But immediately after the second wave started, in January, that positivity rate goes up to 50%, because now people have been more likely to be infected in the recent past, so the antibody is still likely to be positive, and that positivity rate is going to be higher. So what we were measuring until around about the middle of December basically was probably an underestimate, but what we're measuring in January probably is a more realistic scenario in terms of the number of people that were infected, but that itself might also slightly underestimate infections that took place a very, very long time ago. So what are the high-level results? What we see in Gauteng is that 19% of the population in Gauteng were infected until the 9th of January 2021, 19%. Again, to emphasize, you probably should take all of these numbers and multiply by 2. So rather than 19% of people having been infected, that true number probably is closer to 38% of people in Gauteng were actually infected even before the second wave actually peaked. Interestingly, what we see is that there was absolutely no difference in infection rates between children under the age of 12, people between 12 and 18 years, and adults above 18 years. The positivity rate was very, very similar, which means that even keeping children out of school didn't actually protect them from getting infected. They were as likely to be infected as adults when they were outside of schools. Now, what we also see is that people that were more likely to be infected were females compared to males. They were 1.2-fold more likely, so 23% more likely to be infected than males. People that were employed in the production sector, people that are working in factories, as an example, they were 76% more likely to be infected than people that were unemployed. Healthcare workers were 65% more likely to be infected than people that were unemployed. And people with more than one medical condition, such as hypertension, diabetes, they were 63% more likely to be infected than people that didn't have any underlying medical condition. And the most likely reason for that is that they're more likely to be going to healthcare facilities to get a chronic medication, etc. So these are the risk groups of people that are more likely to be infected with the virus. Now, when you look at each of the districts, the range of seropositivity is between 12.7% and 25%. Again, you can multiply that by 2, and it will come between 25% and 50% of people in the different districts were actually infected with the virus until the 9th of January, right? After the 9th of January, when the second wave peaked, we don't know how many more people were infected, but it tells us a large number of people were actually infected in the province, right, till the 9th of January. If you look at the sub-districts, there's a huge variability. Anything between 9% to 43% of people in different sub-districts were actually infected with the virus. So it's not, this infection is not taking place at the same rate in different places. There's different places where there's much higher infection taking place. Now, what this tells us is that until the 9th of January 2021, the number of reported COVID-19 cases in Gauteng that we diagnosed was 330,000. If we use the Sero survey data and we extrapolate it to the population in Gauteng, in fact, the number of people conservatively that were estimated till the 9th of January was 2.9 million. And again, you can multiply that figure by 2 to get a more realistic idea in terms of the number of people that were actually infected. So we estimate, based on the Sero survey, that 2.9 million people were infected with the virus already by the 9th of January, but that figure probably is higher. Now, what this information is also very useful for is that it helps us to understand what is the risk of, what percentage of people that are infected with the virus, not a percentage of people that are hospitalized, but what percentage of people that are infected with the virus will end up dying from the virus. And that figure is 0.28 if you just use the reported deaths of COVID-19, 0.28%. So what it says, about 3 out of every 1,000 people that were infected with the virus, that we diagnosed as having COVID, actually died. But when you look at the excess mortality, which the South African Medical Research Council does, the excess mortality that was reported for Gauteng was 21,500 up until the 9th of January. And then if you use that as your numerator, then the risk of dying from COVID is about 7 for every 1,000 people that are actually infected with the virus. 7 for every 1,000. If you look at the risk of people that are hospitalized dying from COVID, that's roughly about 20 for every 1,000. For people that are just infected with the virus, that risk is about 7 per 1,000. So this infection mortality rate is important. But with the infection mortality rate, unlike the other percentages I've mentioned, you can divide it by 2 now, because we're probably underestimating the denominator when we're doing this, so you can actually divide it by 2. So it tells us that a lot of deaths have occurred in Gauteng, without any question. But the mortality rate, in terms of the absolute number of people that have been infected, fortunately, in a place such as South Africa, has been relatively low compared to many other high-income countries. Now, these are data from the different provinces, and what I've highlighted for you is the number of cases. As I mentioned, the seropositivity rate varied between the provinces, from being 26% in Johannesburg to being 13% in Tshwane. So Tshwane, the district, seems to have been the least affected up until the 9th of January. Now, when you look at the number of cases of COVID-19 that were reported across the province, again to emphasize, it was 330,000 till the 9th of January. Using our numbers from the Sero survey, that figure is about 2.9 million. So about an 8-fold difference. And that doesn't come as a surprise, because the majority of these additional infections that have taken place are people that were asymptomatic or had very mild disease. So they usually wouldn't even be tested or wouldn't even be considered for testing. So that doesn't come as too much of a surprise. So again, to emphasize that the number of there's about an 8-fold difference in terms of the actual number of people that have been infected relative to the number of people that we've diagnosed with COVID-19. Now, I'll come back to this issue. A place such as Sedibeng, as an example that we heard mentioned just now by Bruce, the positivity rate until the 9th of January was 16%. Now, the concern, again, to emphasize, is that those districts with a lower prevalence right now are more susceptible to having larger outbreaks when we have a resurgence, and that is a concern. So that is the reason why this information is important. It helps us to plan as to where we need to focus our attention in terms of trying to minimize the speed of infections that take place in those particular settings. So this is a heat map, and it's difficult to see, but this is at each of the sub-districts now, right? And for each of the sub-districts, what's in the dark red is a higher prevalence, up to 40%, and then the yellow ones around about 10%. So you can see that much of the infection that's taken place, the highest rate of infection has been in the Johannesburg metro, and especially Johannesburg region B. That was 43%. And then when you go out to Tshwane, as an example, one of the districts had a positivity rate of only 9.1%. So important to understand that there's been sort of variability in terms of the amount of infection that's taken place, even at the sub-district level in the same province that we live in. And that has got to do with mobility of people, it's got to do with living conditions. Interestingly, people that are living in informal settlements were less likely to be infected than people that are living in formal housing or in apartments. And that doesn't come as too much of a surprise, because you probably got better ventilation in a shack, unfortunately, and there are fewer people living in a shack than there are people that are actually living in a formal house. Now, you can't see any of this, so don't bother about it. But again, it's just the same information, just to show you that we've got information down to the sub-district level in terms of understanding the number of people that have been infected in each of the sub-districts, and that helps us to understand what to do next. So Mary and Bruce mentioned that there are indications that we need to be concerned about, and this is just another way of looking at the same data which they presented, which shows that in fact for 4 of the 5 districts, what we call the 7-day moving average is on an upward trend, and that is concerning. And my estimate is that if we look at what happened with the first and the second wave in terms of where we are right now, in about 3 weeks from now, we're probably going to be seeing much more cases than we're currently seeing. So we're certainly on an upward trend. We're not at the threshold of a third wave. The positivity rate of the people, the number of tests that are being tested is less than 10%, but we're certainly on track probably to experience the start of a third wave in about 3 weeks. So in conclusion, just to emphasize the high levels, at the provincial level, we estimate about 19% of people have been infected, but probably twice that percentage when we consider that many people tested negative despite them being tested because the antibody has disappeared by now. At a district level, it's around about 12 to 25%, again multiplied by 2, and a sub-district level between 9% and 43%. As of the 9th of January 2021, before the second wave peak, there were 330,000 diagnosed cases of COVID-19 in the province, whereas the Sero survey suggests there were closer to 2.9 million, if not 5.8 million, people in Gauteng alone that were actually infected with the virus. The mortality rate, we're fortunate in that we're relatively lower than what has been experienced in many high-income countries. There's a number of factors that might explain why we've got a lower mortality rate. Now, what is the implications for all of this? Like I said, it helps us to understand which areas are more susceptible to experiencing a larger outbreak when there is a third wave. It also helps, now the third wave, based on this high amount of infection that has taken place, a high percentage of the population has been infected, we expect the third wave to be less severe than the first wave or the second wave, right? And that is the good news, provided two major things. The one thing is that the virus doesn't mutate further. If the virus undergoes further mutations, then we might have a different sort of a different issue to deal with. If the virus remains stable to the one that's currently, the variant that's currently circulating, then we shouldn't have a more severe, in fact, the third wave will be less severe than what we experienced in the first and second wave. But the other important thing, which will influence the magnitude of the next wave, is super spreader events. And if there's one thing that we need to do in a province, and we need to be clear in our mind, is what drives these waves. 80% of all infections, either directly or indirectly, are because of super spreader events. And these super spreader events is when people are gathering indoors in poorly ventilated areas and not taking necessary precautions. So that's something that we simply we need to avoid it as a province if we're trying to minimize the consequence of a third wave. The past infection doesn't necessarily protect people from being reinfected to the virus. But when they get reinfected, they probably will have a mild infection, which is good because our healthcare facilities won't be overwhelmed and people won't die. The past infections that people have had, both were the first variant that was circulating as well as the most recent variant. Fortunately, that past infection, even if it doesn't protect people from developing mild infection, it will still protect people in developing severe disease. So to some extent, a large percentage of people in Gauteng are actually already so-called immunized against severe disease because of the past infection they've had. That doesn't mean that people shouldn't be vaccinated, right? Because we don't know who has been infected and who hasn't been infected. So the focus has to be right now to ensure that we get vaccines into the arms of especially high-risk individuals. I'm not interested about vaccinating the 20 and 30-year-old because they're not going to end up in hospital if they're infected to the virus. But those people over the age of 60, those people with underlying medical conditions, we need to do everything that's within our grasp to get them vaccinated as quickly as possible. So this was my vaccination part of it, my apologies. But like I said, I think we're in a relatively good space right now. And the most important thing is we need to avoid those mass gatherings. We need to ensure that we get the high-risk groups vaccinated. And even if we don't get 40%, or what the target is to get 40 million South Africans vaccinated, in fact, we don't need to get 40 million South Africans vaccinated to get back to a relatively normal lifestyle. What we need to do is we need to get at least 80 to 90% of the high-risk groups vaccinated. And if we can do that, we can pretty much get back to a normal lifestyle. COVID-19 is going to be here for the rest of our lifetimes. We need to become comfortable with that. But it's about protecting people from dying. And it's about preventing our hospitals from being overwhelmed. And the way to do that is to vaccinate high-risk individuals. Thank you for your attention.
And thanks very much, Prof. Mahdi, for that really wonderful presentation and enlightening information about the Sero survey. It's a tough act to follow, but Premier has asked me to sort of summarize what we've spoken about the last three presentations. I think the first point to make is that we have observed a spike in COVID-19 cases in Gauteng in the past week, and this is worrying, it's concerning. And we've got evidence to demonstrate why we're concerned. Prof. Malado presented on the risk indices that are high in some sub-districts and increasing in several. That's the risk of a resurgence. And even though we're saying we have not yet reached a third wave threshold based on the numbers, there are a number of observations that are concerning us. One is what I mentioned earlier, the number of cases is increasing. and the rate at which it's increasing is quite worrying. And the other observation is what I mentioned earlier about the fact that non-pharmaceutical intervention adherence seems to have reduced. So there have been events that have been identified, super spreading events, family gatherings, all sorts of gatherings, religious related, etc. And those two factors themselves are causing us concern. And the third reason why we're concerned is that even though the case numbers right now seem to some people to be low, they're actually higher than they were just before we went into the second wave. And based on our experience of what happened in the second wave, the numbers can escalate very rapidly. Before we went into the second wave, the number of new cases escalated over a 2-week period. We found ourselves having triggered the second wave threshold over a period of 2 weeks from a baseline that was lower than where we are currently. So that's the other thing that's really worrying us. So we've mentioned the areas that are concerning us: Mfuleni, Nsedibeng, Johannesburg D, and Tshwane 3 in terms of COVID-19 cases. We've also identified areas that will be of concern from the seroprevalence survey. There are some districts that have very low seroprevalence rates as of after the first wave, indicating that there are some sections of populations in our province that are very susceptible to getting rapid escalation of cases when the third wave hits. And so that's another area of concern. And the reason why we're concerned, even when we just see cases going up in some selected areas and not all others, is because of what Bruce mentioned about mobility and what Prof. Mahdi also mentioned, the fact that there's high mobility. People in our province are highly interconnected. So you might live in Mfuleni but go and work in Tshwane District 5. And so that means you're moving every day, you're coming into contact with different people. So as long as Mfuleni is at risk, the rest of the province is at risk. We can't let our guard down. Just because I live in region Johannesburg B doesn't mean that it's okay for us to not adhere to non-pharmaceutical interventions in Johannesburg B. All of us have to do that. So based on the Gauteng population-based sero-survey, even if we double the conservative estimate of 19% to 38%, it indicates that yes, a significant proportion of the population is protected. However, not enough people are infected to keep the third wave away. So the third wave that has been predicted is going to come. We still have a number of people who have not been infected, a high proportion, and so therefore there's still susceptibility in the population. Because remember, the way this virus spreads is when a person who is infected comes into contact with somebody who's susceptible. In other words, somebody who's never been infected and therefore not protected by antibodies, or perhaps if their immunity has waned. So susceptibility is still fairly high, but Prof. Mahdi is very correct. It's unlikely that the third wave, will be worse than the second wave because of the fact that a high proportion of people have been infected, and we don't expect the force of infection to be worse. But it is gonna come. And when it comes, the areas that are most concerning, we've at least identified them from the seroprevalence survey, and these are the areas that will likely be targeted first when doing the vaccination rollout. So that would be at least a prudent thing to do. So the best defense right now for us, as we're seeing the numbers increase, I summarize in 2 ways, and Prof. Mahdi did this really eloquently, so I don't want to labor the point. But the first point is about behaviors. And the second point is about expediting vaccination of high-risk people. And these are the elderly and people with comorbidities. And our behaviors are avoiding crowds, avoiding poorly ventilated spaces, avoiding super-spreading events, wearing masks in public, hand sanitizing, physical distancing. So these two factors still remain important, even in the context of a new variant. They're still the factors that are going to control the pandemic and keep the third wave as flat as possible. So we all have a role to play, as much as government has a role to play to continue identifying contacts, isolating cases, and so on. So that's really the summary, Premier, and thank you very much. I think we're all available for questions.
Thank you very much to our professors. At this point, before we present the response of the Gauteng Provincial Government, I would like to just take an opportunity to thank firstly the team, that's the Provincial Advisory Committee on COVID-19, which is a team of experts, public health experts, data scientists, and in many areas also social scientists who understand our province quite comprehensively. Dr. Mary Kaunga is the chairperson of the Advisory Committee on COVID-19. Professor Bruce Melado is a member of the committee. Professor Bruce Melado is a senior scientist at Itemba Labs and the director of the Institute of Collider Particle Physics, and a member of so he teaches and researches at Wits University as part of the teams out of the work we have been doing that are now working with some global institutions. Today we are joined gladly by Professor Madi. Professor Madi is now the Dean of Health Sciences at Wits University. He's a professor of vaccinology. There's a lot of stuff he is working on the vaccines. Although Professor Madi is not a member of our committee, but you would know he is the former executive director of the NICD, which is this key institution that is monitoring monitoring infectious diseases in our country, because he teaches at Wits. So we take advantage of all the expertise we have in Gauteng province. The only thing today is that all of them are from Wits University. Dr. Mary Kaunga teaches there, is a public health specialist, works at Charlotte Maxeke Academic, but also at the Wits School of Public Health. The only coincidental thing is that all of you are from Wits today. But we should say, Dr. Kaunga, that you also work with the various members of the committee from the University of Johannesburg. We do have professors from the University of Johannesburg. In fact, we also have a public health specialist who's in the team, the University of Pretoria. If I don't say this, Professor Madi, they will kill me after this. They will just say that today it was about vets. No, it's not about vets, it's about COVID. But the full team includes the academics from Wits University, Tshwane, University of Technology, University of Pretoria, University of Johannesburg, and other. We have the World Health Organization also has a representative in the team. So I want to thank them, because the work we do is guided by the research work they do. There are many people behind them with whom they work. So on this note, say that in Gauteng province, we have learned a great lesson from the first wave right up to now, which is the post-second wave. And we want to put it this way, and there are indications that we are in the early phase of the third wave. So we have learned a lot, and we always get guided by science, get guided by evidence, the risk mapping that Professor Melado does, which district is of great risk at the moment, which district is a hotspot. But what is different from the work they've done before is what Professor Madi was presenting today. We have quite never known how many people possibly would have contracted coronavirus in Gauteng. So the seroprevalence study today, which was done by the team with a great deal of input from the team from Wits University, and our Department of Health. So for the first time, today we have a sense, some estimation of how many people possibly, and you heard the way Professor Madi was putting it and Dr. Mary Kaunga. So between 2.9 million people up to 5.8 million people have possibly contracted COVID-19, and they were giving an interpretation of what that means. And they have a very positive interpretation. I would like to say that I think the increase in the numbers is of great concern to us. The work that they have now done is also informing our approach to two things, which is the next presentations we are going to get. The first, so this work that they have done, firstly just the risk, the tracking of the pandemic and the mapping of the risk and which districts and which sub-districts are at greater risk and what's the overall risk level of our province. There are two things that we are now doing. So what is the government response? When the numbers increase, there are going to be two more presentations, and those two presentations are about the government response. The first one is about the infrastructure story. Learning from the first wave and the second wave. So how better prepared infrastructure, and it's not just infrastructure, but also health, additional health capacity. Its infrastructure, its human resources, is also health technologies to fight the pandemic. So relative to where we were in May last year, exactly 12 months ago, we are in a much better position. And you are going to see this story. Dr. Maseko is going to present our report on infrastructure and human resource readiness as we facing a possible outbreak of the third wave, because we have been preparing for one possible resurgence after the other. So we have a resurgence plan. So how ready are our facilities? How ready are we with that? Dr. Maseko is going to present that. The second presentation is about how the seroprevalence study and now the mapping of the risk is going to inform our vaccination plan. That is why our vaccination plan must also adapt to where is the greatest risk. So Professor Madi spoke about that. And I want to say that before the seroprevalence study was done, we were treating these regions just based on population density. Now the seroprevalence study is telling us where has the fire already burned. In other words, the virus, so it's clear from the study that the virus it's in Johannesburg, in Sidibeng, where the virus has, if you like, where the fire has already burned in a great deal. And the fire is still burning in Sidibeng as we speak now. And there's some resurgence in Johannesburg. Many of you would remember that Tshwane led the second wave, but Tshwane was not hit as hard as Johannesburg during the first wave. But that seroprevalence study says to us that the fire has not quite burned as much in Tshwane. So the risk is far greater because the number of people who are infected in Tshwane is far less. So we are going to be guided also in our response to vaccination. We also have to go where the risk is higher. In other words, where larger number of people are likely, if the third wave gets to us as it is likely to get to us, and Dr. Mary Kaunga says it is coming. So which areas are likely to be at greatest risks? So we are going to go, therefore, and look at those areas, those sub-districts, and also those regions where we have larger number of people who are not infected, which means they are at greatest risk for the third wave. But it is not everybody there. You know, we're going to start with people who are at the age of 60 and above. So we are going to reorganize. So when we do our second phase vaccination program, and Ms. Mupe is going to present where we are with that planning now. You put this behind your mind. You must understand that we are going to go to where the fire has not yet burned, because if you want to put the fire out, you must know that in areas where the fire has already burned, it means the risk of catching fire there is less. The scientists are not using my language. I am talking to the people of our province. I'm not using your language. So the seroprevalence study tells us, so which areas are more susceptible? So which means which areas are likely to be hardest hit by the third wave, because they were not hardest hit by either the first and second wave or by both of them combined. So when you saw in that report presentation by Professor Madi that Tshwane has a much lower infection rate, it must be of great concern to us. So the area where you have had much lower infection, so it's, in other words, the logic is the other way around. Johannesburg has had more infections, which means, and again, this is what is being presented, which means that even as we roll out the program there, we must do prevention at one level, jack up the infrastructure capacity, and as we deal with the vaccine rollout, we must jack up testing, tracking, and tracing. It is very easy, and I want to say it's very easy that we can direct all our resources to the vaccination program and forget that we have to test and track and trace all the people, because the fire is burning, and the fire is likely to burn more in areas where it has never burned more. So we can't focus only on the vaccination problem. That's the point I want to sum up. We know vaccination is important, but we will only be able to get a certain number of vaccines. So our strategy is therefore going to be combining vaccination, the vaccine rollout based on the number we will get. But we are going to also be getting the troops out there. And these troops are our tracking and tracing teams. Significantly ensure that we can track and trace in the areas where the risk is higher, but also the outbreak is happening in the hotspots. We're going to ensure that we continue to deploy the tracking and tracing teams more effectively, because the only way to put down the fire is to contain it in the areas where we know that the potential for it to burn more and a long burn, to have a long burn, it's in areas where they have been less affected so far. Less affected has been good during the first and second wave, but think of it this way. The less affected are the greatest risk for the third wave. And that's what we are going to be focusing on now, to ensure that the infrastructure resources of the Provincial Government Department of Health are also aligned to where the risks are. The ambulance services, the availability of beds is fixed, we know, but where we know the risk is greater, to ensure that we can be able to move people for cases of admission. So at this point, I would like, therefore, to Maybe let's do a post. Do you have questions for professors before we present our full response? Because I know if you deal with the questions for professors, we are done, then we will deal with our response. Thabo, just check what the media is comfortable with. At the end, you are the media too. So these two presentations will be, this is the Gauteng Provincial Government's readiness for the surgeons, as well as ongoing work for the vaccination program, the vaccine rollout. So we'll start with Dr. Maseko, who's going to give us an indication. There he is. He's responsible for infrastructure, health infrastructure in the Department of Health. And he will be followed by Ms. Mope, who is the COO of Health, but she's responsible for she's driving the vaccine rollout plan in the, Dr. Maseko, you can't be too long. You are not a professor. You are a doctor, but you can't be too long.
Good day, Premier, MECs, colleagues and members of the media. I've already been introduced by the Premier. Thank you very much. This is infrastructure on COVID, which what the province really had to plan. When we had to respond to what was early modeling, the predictions were that we'll need 2,400 critical care beds and 7,500 general beds. We therefore had to sit as a provincial team represented with multiple departments, and we came up with quick wins and then also what might be immediate and then what could have been, we'll say, long term in the context of within what we're discussing about, and decanting of what's in existing facilities just to create dedicated beds for COVID-19. And we quickly, that quickly was able to give us 1,925 beds, which was as follows: 373 critical care beds and 1,552 general beds. We then had to do repurposing of additional identified space, including undertaking major refurbishments and renovations to create additional beds. You'll see later how much that it gave us. We then had to go for creating permanent infrastructure within our facilities. And what was available for us was alternative building technology, which is modular and also has got the same lifespan as the brick and mortar. And then finally, we then had to consider field hospitals. And we were clear that should a need arise. And then the number of beds, then when we're coming from planned and then completed through the major refurbishment and renovations in facilities, has included 565 critical care beds, 282 general beds, and then we've recently opened BMW, which is an APT structure of 150 general beds at Brongolspruit. Then we had, in terms of the third approach of permanent structures, we had planned 1,575 critical beds through 4 APTs and a facility at Anglo. That was a mine hospital, and then we converted into a critical care component. And to that end, we've already completed and handed over Jubilee and Chris Anipara, full and then full in terms of health technology. We've completed, but we have not commissioned 150 at Dr. George Mkari, and 175 at Anglo. That gives us the 325. And then we are yet then to complete by 31st May on the other 150 at Dr. George Mkari, and then 300 at Kopano. That's the 450. We are fully aware that we then had commissioned NASREC, which we have subsequently decommissioned. As we are ramming up infrastructure within the province, we then decommissioned NASREC, and that's fully decommissioned now. And those beds are catered for within what we have created. And then when we started, it was 1,925. Then by first wave, we had already added other in terms of facilities to get us to about 3,062. And then we continued to ramp up and deliver, and by end of January, we're already at 4,265. So the 1,193 is just the other beds that we're then to add as we're then ramping up to. But as the infection also subsides, we then had to also give out in terms of those beds so that we can, in terms of the other services, as we opened our services, and then we then decrease within that. But fortunately, as we have already had other in terms of beds that we've indicated with, which you will see that already Brongospruit have added, the province will then say the province has then made 4,415 beds. Unfortunately, through the fire of Charlotte, we then had to at least give out 221, which were dedicated at Charlotte, and the 90 at Discoverers, which we are using to support the services of Charlotte. But we still have currently functioning and with staff, head technology, 4,664 beds. And they are as follows: 3,261 for admissions in terms of all beds, and then 803 quarantine and isolation, which is inclusive of Brongospruit. And we have not added the 500 beds that has been complete and equipped at Para, which we can still add to this 464. And then the human resource, that as much as it's a limitation, but we do have agency that we can always call on to, which then assist, because that's where we can redirect in terms of as and when the trajectory points us. This is just about Anglo, to say that we're already started to install health technology so that by next week Friday, it's ready for occupation and ready for third wave, should we need it in terms of COVID. I think we've talked about Dr. Justin Curry. The human resource that has been made available, additional to what currently we had, is 5,438 employees, and they've been appointed, and we've also, in terms of the contract, extended them because COVID is still with us. We also have an additional 480 from the agency that is then available. And the clinical team continues to ensure that at all times the patient needs are catered for through the resources that have been made available. And this is just in line with tracking in terms of virus. So as we've heard that we need to now ensure that at least the districts or sub-districts at least is able to then, in terms of the patient care and needs, from a total infrastructure point of view, which is health technology, human resource, and create a proper service. Oxygen availability. With AFROX, we've continued to engage, and we meet frequently. And when the infection subsided, they had taken some of the cylinders that were dedicated to facilities, but they've committed to reissue that additional one as we then track. So also from the Premier, from the oxygen availability point of view, we are very comfortable as a province for all the beds that we've made available and we're still going to make available. Also on Charlotte, the facility, the Premier will talk much to it, but the facility will be opened in a phased-in approach. and then we're giving priority to the safety of both staff and patients. All support services that are being prepared for occupation, and we'll start with oncology, obstetrics, and gynecology. Those are the ones as we move in within the in terms of a phased-in approach. Deep cleaning is ongoing, as some sections we have already cleaned, and we are happy that the structural assessment of the building sections that have not been affected by fire has been concluded, as we had, Premier had demanded that we made the whole facility to be safe, and the report has declared the structure to be sound, in a sound condition, and can be ready for reoccupation. The fire inspection has been concluded as well, and we, by today, will be getting the air quality testing results, or we've been promised by end of the week. We just hope that we'll be able to get it today, so that then we can be able to then move in a phased-in approach. Thank you very much. Premier, we still on track for the 10th, because everything else that we there, and even the team has done a walkabout even today there, and indeed we believe that will be phasing in. The phased-in movement will start from the 10th. Thank you, Premier. Thank you, Mrs.
You were given many numbers by the doctor from infrastructure. When we started with COVID-19, then the number of beds we had was 1,193. The total number of beds we have been able to build now, and I'm adding the ones that are complete. We are opening on next week. Anglo Gold, Ashanti, we have completed. Chris Hani, Baragwanath, because it's complete, and there's interesting discussions about what else it would be used. There would be 4,564. So the DDG there, Dr. Maseko was saying, is 4,064, and then he said plus Chris Hani, Baragwanath, ABT, that is 500. So that's 4,064 plus 500. So that's 4,564. And he has minus some of the beds that we have. We would not be able to reopen immediately at Charlotte Mateke because of the fire. That's the northern block. So what does this mean? And he also spoke, so from a health infrastructure point of view and additional staffing, we are in a better position now than in May last year. May last year, you would know, that's when we were, the indications of resurgence that led to the first wave were beginning to happen. 12 months later, we are much, much more better prepared. One important question with COVID is the availability of oxygen. If you ask the question, what have you learned? The availability of oxygen is quite critical. So he was answering that question too. And from where we stand, so availability of a bed is one thing, but what goes with the bed is the staffing, the care. But in many instances, once patients are admitted, now there's more knowledge from the scientists that oxygen saves life. So the availability of oxygen is one of the things. Having learned from the first and the second wave, we want to make sure that there are no beds just available and staffing, but that oxygen, and that's one thing that we have been paying great attention to. So there's no difficulty with the supply of oxygen. Again, that's learning from the first and the second wave in that kind of a situation. So that, in that sense, again, I'm also saying the provincial government has has increased the availability of the budget for staffing. We know that healthcare workers were severely impacted by being overworked at that time. So this additional 5,438 healthcare workers will help us. We know that some of them is not permanent, but in many hospitals we have been going to, the healthcare workers have been saying, yes, we are understaffed, not just for COVID, but also for other specialist services and other health services. So our response to COVID is not just for today and not just for COVID. That's why even the hospital refurbishments and the ABT we are putting is not field hospitals. I want to clarify that. What we have been putting, these are alternative building technology structures that will last 20 years or more, because field hospitals means you dismantle. Yes, Nasrec was a field hospital. You dismantle. You use a stadium, as you have seen all over the world. You use a conference center, but you dismantle when the resurgence is gone. But what if the next wave comes? Professor Madi says we are going to live with this for a long time. Many countries thought it would be first wave, only they went through the second wave. In Europe, they went through the third wave. So the wisdom of putting in place permanent structures to expand the healthcare services, rather than rushing to use temporary or field hospital facilities that would be dismantled. So yeah, the only one we used was Nasrec. And it helped us a lot. Nasrec helped us a lot. At the moment, if you ask a question, will you need Nasrec? At the moment, we think we have built sufficient capacity in-house. But you never know. You never know with this pandemic. We can't say never. But at the moment, we have capacity. So Nasrec was shut down because we have existing capacity. And we hope the indications that the third wave may not be as severe. We hope the behavior of our people as a whole will help us, that it is not severe, so that we don't need too many additional capacity. But so this is for the resurgence. So this is the resurgence plan. Whether the third wave comes or not, but whenever there's going to be resurgence, we have built additional capacity. Third, fourth. But what about the vaccination plan? Because the vaccination plan is also about, yes, indeed, dealing with avoiding future outbreaks. So Ms. Mupe is ready to present our vaccination plan. We are doing it on both sides. It's both dealing with the long term about vaccination, but also dealing with any resurgence that happens immediately. Ms. Mupe, over to you. Ms. Mupe, you are the chief official in charge of vaccination. Can you summarize it? Can you summarize it? I know you can speak the whole day.
Good day, members of the media. As the Premier says, yes, I can go on and on and on, but I have to respect his wish. And I also would like to request that I don't use the mask, because my voice sometimes, it starts on a high, and as I present, it goes on the low. And with Dr. Masego, I couldn't hear him very well from where I was sitting, and I think it was because of the mask. Today I'm going to just to give a brief update on how far we've gone as the Gauteng province with the vaccination program. We all know that it started in February and we started at Steve Biko Academic Hospital as well as Bara. But we've since expanded to most facilities in the province. We have also now started preparing for phase 2 of the program, and we then have added then 35 hospitals and then 249 non-medical sites to prepare for phase 2 of the vaccination program. So since that start, as at the 6th of May, as Gauteng, we vaccinated 90,346 health workers under the Sisonke protocol. And when the Sisonke early access study ends, in Gauteng would have vaccinated just over 112 healthcare workers. So the remainder, because we're supposed to be vaccinating 215,101 health workers, so the remaining health workers will be vaccinated once the Sisonke protocol has ended, and we'll be using the Pfizer vaccine to do this. So we all know that the Pfizer vaccine was delivered in the country a few days ago, and of the doses that arrived in the country, we were allocated just over 61,000 for phase 1B in the province to complete the remainder of the community, the healthcare workers, we were told that phase 1B will begin on the 17th of May, but Premier is really pushing us. We may even consider starting before then. As long as we've got the vaccine as Gauteng, we run and we vaccinate. And to date, we have got 235,000 people that we've registered on the EVDS out of the total of 626,000 that have been registered nationally. This is how far we've done as Gauteng. You can see out of 366,101 vaccinations that have been conducted in the country, Gauteng is at vaccinated 90,346. We vaccinated the most because as soon as we get the vaccines, we run and we vaccinate. So these are the number of sites that are allocated specifically for the Pfizer vaccination. We've got 21 of them. The metros have allocated 5 sites, and the district municipalities each have got 3. So for now, we have sort of set ourselves some targets of the number of people we'll vaccinate per day and how many they will translate into per week. These numbers may increase depending on capacity and also depending on the number of vaccines we receive. The more vaccines we receive, we expand the capacity in terms of manpower and infrastructure, and we vaccinate. In terms of phase 1, as an update of phase 1B, we have identified the sites as I've shown in the previous slides. And in 1B, we will focus on the healthcare workers, as I said. We'll also add the traditional healthcare practitioners in this, as well as a funeral parlors, because they also remain the vulnerable population. And as I said, we've got just over 61,000 doses, and our storage facilities, we've assessed them. They are in good working order for distribution of the vaccines as they arrive. And as I indicated, our hospitals are also involved in the Sisonke, and they'll also participate for the phase 1B of the program. These are the medical sites that are going to be used for the phase 1B of the vaccination sites. In total, there are 285, and the public sector has got more sites at 185. But over and above this, we do have non-medical sites. We've got 249 of them that are also going to be vaccinating. We went all out to go and inspect and prepare for phase 1B because the numbers are big, and we need to make sure that we go outside of the normal public healthcare facilities to ensure that we cover as many people as possible that are vulnerable, that must get the vaccination. We are now currently implementing, it's our plan that we developed to ensure that we vaccinate those that are above 60 years and older. As Professor Maji said, we really need to be focusing on those that are vulnerable, and we are grateful for the insights they give us as the Department of Health, because then we learn from what they are coming up with and we program accordingly. So we have deployed community workers across the province to assist the elderly in their homes and other settings to ensure that we register them on the EVDS in preparation for vaccination. So to date, we have registered 235,202 persons that are over the age of 60 on the EVDS system. What we would like the system to do is for it to generate the numbers per district and per sub-district, in line with what Professor Mati has said, so that we know which districts have vaccinated the most and which ones have vaccinated fewer people, so that we send the troops to go and target those areas that need urgent attention. And we are continuously monitoring our sites to ensure that they comply and they continue to meet the requirements of the vaccination program. Over and above this, we've also done outreach campaigns to register the elderly. We used an intersectoral and intergovernmental approach where the Office of the Premier was also leading us and all other departments in ensuring that we go on a massive and robust registration campaign. And we targeted areas such as the residential areas for older persons. We've gone to community-based centers, service centers. We've also used the SASA points to target the elderly and assist even those that are maybe younger that don't know how to vaccinate. We do tell them, however, that priority is going to be given to those that are 60 and above. When their turn comes, they will be vaccinated. We've also gone to the elderly that are living in their own households through our community development workers and community workers to assist to register. This is the population that we must do as Gauteng. For now, we're targeting the 1.3 million of those that are above the ages of 60, as well as those that are between the ages of 40 and 59 years, especially those that are living with comorbidities. They become priority for us. So those are about just above 3 million. So those are the ones that we'll target. And then phase 3 will then be the 6.7. That is those people that are between the ages of 18 and 39 years. Just in the past week, we've gone out to register just above 21,000 persons that are over the age of 40 in the residential areas. And the table below shows you how many people were reached through this robust campaign. And some of the districts have already exhausted the number of people that they were registering in the old age homes, as you can see them. So the number may increase because the registration is continuing. And as at the 6th of May, 1,907 people were called through our hotline, and out of those, 8,004 were registered. So that gives us close to about 53% of those that were registered using the hotline. And we also are embarking on the bulk SMS campaign to reach over 500,000 people on the database. I think I'd like to end here, Premier, and leave the concluding remarks to you. I hope I was short, Premier. Thank you.
Okay, something else has happened. Okay, so I think one of the things Ms. Mupe did not say is that we have picked up, the professors, this is very important, we have picked up that since the suspension of J&J, because of the issues around clotting, since that time, there is a bit of reluctance or hesitance. Prior to that, there was a lot of enthusiasm in the interaction with people on the ground about registering for the vaccine. So this, we disclose in this because it means there's lots of work we have to do to explain. So that period, the period, and it was necessary, and we understand it was driven by decisions based on the work of the scientists. But since then, it has been a little bit more difficult. This past week, we had lots of interaction with the elderly people at the old age homes and at the pension pay point. And they were asking questions about clotting. They were asked, it means that they listen to they follow the news very closely, and they were asking questions around safety. So from the point of view of the provincial government teams, we're going back to the drawing board, because we have found that even the old age homes where people had initially indicating that they are waiting for the vaccine, there's a little bit of no, we need to consult, or family member must come. So we want to appeal to the people of our province that vaccination is extremely important. I want to appeal to families of the elderly people of 60 and above, because some of them, when our teams were interacting with them during the pension payouts, were saying that they need to consult with family. It's a new question that has arisen, and it revolves around that period of it was called suspension of the J&J. So, but from where we are, our message is clear. We want in Gauteng province 1.3 million people 60 and above. Only 235,000 have registered. So we still have a very long way. And I want to say that we had thought the uptick on registration will be higher, especially where our community health care workers are now helping people to register. But there is a little bit of reluctance arising from, and this is a question, is it safe? And are the issues of clotting sorted out? So I want the professors, who are here, Professor Madi, as the professor of vaccinology. I want to put that question to you so you can respond to this public concern that our community health care workers have reported, that it is an issue now. But from the point of view of the province, we want to register all the 1.3 million people. We want to roll out this vaccination program as soon as we can, and we will do everything to remove all the bureaucratic obstacles. We don't want any potential vaccinee not to be vaccinated. So anyone who qualifies to be vaccinated, it can be because of bureaucratic reasons. That is why we are deploying our teams to help to register the elderly people. You don't have to have technology for you to be vaccinated. So we are sending people, they are doing door-to-door work. We are sending our community health workers and our community development workers. They have their own gadgets to help register people in their homes. So I want to assure the people of our province that there will be no obstacle. We just want you to be willing. And we want to persuade you that vaccines do save life. Please come along. When we get more vaccines and when we start to get more vaccines, we don't want to encounter a problem of those who don't want to take vaccines. So we're also using all the capabilities, hotline, and all other mechanisms to reach every part of our province. Because we don't want to register only those who are in formal housing, who have the advantage. We want to reach every part of our province in that regard. I have emphasized vaccines save life, and that's an extremely important message to get out there. But we can do all other things. If the people of the province do not respond to the need to observe social distancing, to sanitize their hands and wash their hands as often as possible, and to avoid crowded places and closed spaces. We know we are getting to winter, like it's chilly this weekend. It's very easy for people to be tempted to gather in closed spaces. The virus is looking for those opportunities. It is extremely opportunistic. It's looking for opportunities where the places are closed in. So we really, and the team is telling us, the research team is telling us that we have something like the fatigue. And my message is that we must defeat the fatigue as a way to defeat the virus. We shouldn't allow fatigue to set in. That COVID fatigue, in a situation where people say we are tired of doing all these things. It saves life to do all these things. The reason in Gauteng we have lower infection comparatively during the second wave is because people got the message. They got the message that we are moving in a dangerous situation. Like we are saying now, there are indications that we are moving into a dangerous situation. And we are appealing to the people of our province that without them we will not win the war. So they shouldn't tire. They shouldn't feel fatigued. We are appealing to them, to the people of our province, to continue because we will defeat what is coming ahead of us. This storm can be less severe. The third wave can be less severe, much less severe than even the second wave, which was less severe than the first wave. It is only possible if the communities understand that it is about saving lives. Because the vaccines are going to reach more people much later. So I can't stop appealing that we have won the battle of the second wave, which we did. By all indications, the second wave was less severe in Gauteng. We didn't win that battle because we were clever, but because we communicated and worked with communities. Because the healthcare workers did the best that they could. And let me tell you the difference between the second and the third wave. The second and the third wave that may come is that healthcare workers are much more motivated now because a lot of them have taken their vaccines. Of course, there are still healthcare workers who have not taken their vaccines. And we hope that there will be more healthcare workers. I have met healthcare workers in the last 2 days at Brongo Spruit Hospital and at Mamelodi Hospital who are saying, we are ready for the resurgence. The fear that they had during the first wave and the second wave, the fear and anxiety that they had, a lot of them were saying, we have taken our jab. We are much more motivated now to face this storm. But the communities are our way out of this situation. So I want to conclude therefore here and say we really rely on the response of communities, and the professors can explain, and Professor Madi and Dr. Mary Kaunga can explain a little bit more about whether the people should be concerned about blood clot again. Thabo, you can take, we are ready to take questions. You can take over. This is for you now.
Okay, we will take questions. The mic will move around. Just raise your hand and please introduce yourself before you speak. Yeah, please go ahead. Yeah.
Ngobile Madlala from ENCA. I just want to ask from the Premier, he's specified that there's infrastructure and that the province also has added staff members as well as a vaccination plan. But how confident is he that we are going to win this war on the third wave?
Okay, that's the question for the Premier. Is there any other question? Is there? Okay. That's the only question we have. Let me check one that was sent. I have a question here from Business Day, from Luyolo Muketana. Is Gauteng going to consider quarantining and or testing travelers from high-risk countries, including India? I think, yeah, those are the questions we may answer, Premier. Prof. Madi and Dr. Mary Kaonga, your comment on the vaccines? Yeah, please come forward.
Issue of vaccine confidence is something that's really important to address. And I think it's really important for us to put it into perspective. So with the Johnson & Johnson vaccine, the rate of this clotting event is about 1 in a million. With the Pfizer vaccine, it's about 5 in a million. And most of these severe adverse events, about 1 in 5 of the people that develop these conditions would die. So even with the Pfizer vaccine, where it's about 5 in a million, 1 out of a million will die because of this particular side effect. So that context is really important. And most of this clotting is taking place in individuals that are under the age of 40, and for some reason more so in females. Now, when you're looking at people that are over the age of 60, if 1,000 people if 1 million people over the age of 60 get infected with the virus, the number of people that will die is 60,000. If 1 million people over the age of 60 get infected with the virus, the number of people that will die is 60,000. Okay, if 1 million people over the age of 60 get vaccinated, the number of people that might die from this complication is less than 1 in a million. So we need to remember when we're talking of side effects, yes, it's important for us to be looking at side effects, and in fact the province needs to invest to make sure that we've got robust systems in place to measure the effectiveness of the vaccine as well as the frequency of the side effects. We need to do that. It's really important because it gains public confidence around the issue. But when we're discussing these issues in the media, we really need to put it in a context in terms of if 1,000 million people are infected, how many people will die? And if 1 million people are vaccinated, how many people are going to die from this complication? And I think that balance really needs to come. And it's actually a media responsibility to educate the public and to actually emphasize this risk-benefit ratio. While I'm here, I'm just going to take the liberty of addressing the question that they asked you, actually, about the issue of defeating the third wave. We need to be clear about what do we mean by defeating the third wave. If we mean that we're going to get rid of the virus, that's not going to happen. Like I said, the virus is going to be with us for the rest of our lifetimes. But as the Premier has pointed out, and as Dr. Maseko has pointed out, we're actually in a good space in terms of bed capacity. The biggest challenge that we face with the third wave is whether our healthcare facilities are going to be overwhelmed and the number of people that are going to die. With the increase in capacity in our healthcare services are not going to be overwhelmed. With the security of oxygen that we've put into place, our healthcare systems are not going to be overwhelmed. And if our healthcare systems are not going to be overwhelmed, it means that we're going to be able to mitigate the consequences of severe disease, and we're not going to be able to minimize the number of people that will die. So people are still going to die, unfortunately. Until we get almost every high-risk individual vaccinated, people unfortunately are going to die. But the numbers is important. And what we've got in place right now in the province, and because of what's happened in the past, we're in a good space in that we're unlikely to see healthcare services overwhelmed. And if that is a victory that we're wanting, then that victory we will achieve.
Prof, has put it well. I just want to add another variable, Prof, that avoiding super spreaders. So if we add if we can succeed to ensure that the super spreader events, there are no major events that would lead to larger numbers that may make it difficult to cope with the infections. And that is a function, firstly, yes. From a point of view of government, I think we should ensure that we enforce the regulations, but it's the issue of community behavior and public behavior. So I would say that I think confident of winning as of ensuring that the third wave is not as severe as what we have gone through during the first wave or even during the second wave. And one thing I can vouch for is that with people's cooperation, adding the capacity that we have built, and with people's cooperation and collaboration and firmness, I must say government must also be firm in enforcing the regulations. Firmness, if we say the following things shouldn't take place, they shouldn't take place. And because one thing we really want to avoid is the shut down the economy. We cannot afford. I think it is clear that we cannot afford to shut down the economy. If there's something that we really wouldn't want to see is a situation where the economy is shut down. And the way to avoid it, I think, is to take charge. And taking charge means get a lot more people to be more conscientious, wearing masks, social distancing. And I want to say to younger people in our province, the youth often drive this risky behavior about gathering in larger numbers in places. If you want to know why in Tshwane we had that outbreak, it's young people who drove the outbreak in November, December in Tshwane. It's young people. We were very concerned just monitoring the numbers at the University of Pretoria, the outbreak that was contained there. It's young people. And we also know where they gather. Where are these places where they gather? And in larger numbers, even during the weekends, and they party. I want to say that I think, even though we are still in level 1, but a situation requires a sense of emergency. We don't want the campuses and the students in the neighborhoods where the students live. Often that's where we have, and in the townships, in hangout areas where young people hang out. We don't want those to end up being our super spreaders. So I'm quite happy that we can win. And winning doesn't mean that there will be no infections. It's as defined by Prof. Madi. I was asked this question yesterday. Would you recommend that the flights from India must be banned? I said, when you deal, one thing we don't want as South Africa, we don't want the stigmatization of any country. Because there was a period where there was said to be the South African variant was a factor of stigmatization. Yes, this variants, this would be, so these viruses, yes, they would be different, but we don't want a situation consciously or unconsciously to start stigmatizing a country. This is a global pandemic, and there may as well be different variants in different parts of the world. We need a response, a multilateral, coordinated, solidarity response. We want all the countries to be working together to focus where the greatest problem is. We are deeply concerned that India is going through what it is going through. You know earlier on Brazil went through a very, very difficult period. I don't know if they're out of it at the moment. Different parts of the world would have gone through that. There was a period where Italy, Spain, and the UK went through those. The point we are making is that you can't stigmatize a country. Every country needs to take measures to ensure, yes, in accordance with the risk adjusted strategy. When the numbers increase, yes, it will require the National Coronavirus Command Council to look at that. We will make an input there. But we don't want to stigmatize a country. So this point is my emphasis, because simply taking a decision that you're shutting out these countries, the travelers from that country and that country, we want a comprehensive approach. We want a comprehensive approach that says the level of risk is at this level. Should we re-look at the ports of entry? Remember, OR Tambo is a port of entry. It is in Gauteng. You have other ports of entry. You have ports of entry like the borders. Yes, when the risk increases, it does require that you look at your risk and look at all the contributing factors. And if the ports of entries should be looked at, you do that comprehensively. But you can do that without stigmatizing a country, because that stigmatization can have some level of subliminal racism. That's the real danger. When you are dealing with pandemics, you are dealing with a threat, an existential threat to humanity. And it should elicit a human solidarity, a comprehensive response. We should feel the pain that people are feeling in any part of the world where more people have succumbed or are dying. We should feel that pain. Yes, we must take measures to protect ourselves internally, but just the notion that something will be driven by flights from a particular part of the world. I think at the moment, professors, at the moment, this resurgence we are looking at, there's no indication that it is driven by a variant from somewhere else. And that's why we are focusing on improving the situation. But if you are, personally, I'll be very opposed to the idea of turning a pandemic. Every stigmatization of dealing with an epidemic or a pandemic is your first defeat. We have learned that when we're dealing with HIV and AIDS. Once something is a stigma, it's your first defeat. And it is worse if it's a stigma that is now linked to a country or a particular region in the world. So we would not want an approach like that. But it doesn't mean we can't review the risk of open ports of entry. We have to do that, but it must be driven by science, it must be driven by numbers, it must be driven by indications of the real risk that is being brought into our shores by pandemic or a variant from another part of the world. So that's what I would really emphasize. And I would like to thank you for this. Let's get the message out to our people that we are ready, but we will never be ready without the support, the full support and cooperation of the people, because that's where it really matters. We can be ready on the part of government, but we can only be 100% ready with the cooperation of all the people on the ground who are the ones most affected by this pandemic. And I have no doubt, on that basis, I have no doubt that we will win. I have no doubt that we will win, and I have no doubt that we will also win the cooperation of the people, because the consequences of not winning that cooperation. And the consequences of not containing the pandemic are too ghastly to contemplate. Certainly, we don't want to see what is taking place in India and what happened in Italy at some point, and in Spain at some point, and in Brazil at some point, and in the US at some point, and in the UK at some point. So thank you so much.